Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. In today's episode, we'll be talking about a wide range of topics surrounding amyloidosis. I'm happy to have with me Dr. Kevin Alexander, an advanced heart failure trained cardiologist and assistant professor of cardiovascular medicine at Stanford University School of Medicine. Dr. Alexander specializes in the management of advanced heart failure and transplant cases, seeing a wide range of patients. He also has an active research lab studying various forms of heart failure. Dr. Alexander has expertise in diagnosing and treating transthyretin cardiac amyloidosis, a critical yet underdiagnosed cause of heart failure among African Americans and the elderly population. He is conducting extensive research to enhance our understanding of this condition, with grant support from the National Institutes of Health and American Heart Association, among other sources. Welcome, Dr. Alexander. It's an absolute pleasure to have you on our podcast today.
Yeah, thanks for having me, Mackenzie. I look forward to our discussion.
Yeah, absolutely. It's always extra special when we have an amyloidosis expert such as yourself from a center of excellence such as Stanford. And I know all of us in the community have seen amazing forward progress over the last 10 years. So much has changed, whether that's knowledge about the disease or diagnosis, treatment, and even the outlook for patients. It really is astounding progress. I look forward to hearing your insights about the world of amyloidosis. But to get things started, let's begin with your thoughts about an all important question from our patient community. And that is, will amyloidosis ever become a survivable chronic disease?
Yeah, Mackenzie, I think the short answer to that is yes for both ATTR and AL amyloidosis. We know that outcomes vary significantly on how early you diagnose this and um, how quickly you start treatment. And it's becoming increasingly clear if we diagnose patients earlier that the treatments we have available now can really slow down or prevent those diseases from progressing. And my optimism and hope is as we get more developments for treatment, that those folks with more moderate or later stage disease will also be able to halt or potentially reverse disease. So I think we're constantly moving the needle. And like you said, there's been a lot of advancements in terms of treatments. And so we really need to continue to work on raising awareness so that we can diagnose most people at the earliest stages.
Yeah, I think I speak for all patients in expressing how excited we are that, you know, this really is becoming a disease that has a very different outlook than what we thought even 5 to 10 years ago. And even more so, like you said, for those patients who are more moderately or sicker, right, getting diagnosed later and having more significant disease when they are diagnosed, that at some point we also have hope that their outlook will be more of a chronic disease picture rather than a more terminal picture. Um, but as someone who cares for patients with amyloidosis, both AL and ATTR, what would you say the cardiologists would want their cardiac amyloidosis patients to know?
So I think from a cardiac amyloidosis perspective, that, and I guess to clarify your question, is this kind of what the perspective of a general cardiologist or an amyloid expert? Could you
I would say
clarify?
more from the perspective of an amyloidosis expert.
Yeah, I mean, I think from a cardiac standpoint, I would say that it's important to diagnose cardiac amyloidosis early, like we were talking about, because this can be a progressive disease, and a lot of times the cardiac manifestations can be the thing that causes the most symptoms and can impact survival. So I think that not that other organ systems are important, but a lot of times the cardiac involvement can be the thing that causes the most issues. And I think that along with the treatments that have been developed for ATTR and AL cardiac amyloidosis that are increasingly effective, we're learning more about how to manage the other kind of other aspects of these diseases. So what I mean by that is, how do we manage the heart failure? How do we manage the arrhythmias? How do we manage things like lightheadedness due to
Mhm.
blood pressure changes? All those medications and interventions that complement the amyloid specific therapies, I think we're getting a better understanding of. So I would definitely emphasize that those are important uh, pillars to how we take care of patients with cardiac involvement. So it's not kind of start an ATTR or AL treatment and then you're done. There's a lot of things that we can do kind of immediately to help with symptoms, making sure the diuretics are the right doses, that we adjust some of the other medications that could be causing fatigue and low blood pressure. So I always like to frame it in when patients are newly diagnosed in my office, that what can we do today to help you feel better? And then what's the big long-term picture for how to improve your outcomes? And so I think it's important to kind of set those short, medium, and long term goals and expectations.
Yeah. And, when I think about those kind of goals, and are you connecting them or working closely with their primary care physician to manage some of those more short-term goals, or are a lot of those managed by you as a cardiologist?
I think a combination of both. Each scenario is a little different. I'd say for most patients, though, it takes a village to take care of amyloidosis patients. So there'll be multiple physicians and stakeholders. A lot of my patients don't live near Stanford, and so they have a local primary care doctor, a local cardiologist, maybe other specialists involved, and they're really the ones that have oftentimes known the patient for many years. And so
Mhm.
their input and their um, expertise in management are really important. And particularly if things come up acutely, they're often the ones that are going to be seeing the patients faster than I can. So it is a partnership and a collaboration, and I think it works the best when those other physician stakeholders are involved. Not to say that I can't manage those things, but it helps to kind of me to focus on maybe more of the amyloidosis specific issues, and
Mhm.
have someone locally that can help with symptoms as they come up. So I think that at our amyloid center and others, we're very flexible with
Mhm.
what individual patients needs are, but if there's support locally, that really helps a lot.
Yeah. And to build on that, you talk a little bit about kind of the provider to provider relationship, how you have to work collaboratively with other healthcare professionals to really provide your amyloidosis patient the best possible care that you can. But on the flip side, the patient to provider relationship is also an interesting dynamic and piece that you deal with. So could you speak a little bit to how can we kind of optimize the patient provider relationship, um, and are there things that patients can do to be um, kind of make your life as easy as possible, and um, something like that, like how are there any tips you have for them to be prepared so that when they come and see you, they're you can maximize your time together.
Yeah, no, thanks. Interesting question. It's kind of a two-way kind of question. What can patients do to make our lives easier? But much more important, what can we do to make patients' lives easier as they navigate complex and complex disease? So I think the things that we try to do to make patients and their caregivers' lives easier is really to um, have open and accessible communication pathways. And so what I mean by that is, we see patients in the clinic, let's say every few months or whatever that is, but that's not the full extent of the relationship. So we're fortunate to have dedicated nurse coordinators that are frequently in communication with patients to help them navigate scheduling appointments, follow up on testing, answer kind of logistic type questions. We utilize a lot of telemedicine, which
Mhm.
allows us to have more frequent visits that don't require frequent transportation and drives. In California, it's not uncommon for patients to drive hours to see us in clinic. And so if we can have some telemedicine visits in there, that can cut down on burden, caregiver and patient burden in terms of transportation and time. And we also try to avail patients of all the great uh, patient support group resources that are out there. So we partner closely with them. So I think that we try to really make it so that it's easy to reach us when questions come up. We're proactive in reaching out to patients, maybe even before something comes up, to make sure that we can try to preempt things. Um, and in terms of what could make our lives easier from a patient standpoint, I'd say I wouldn't worry too much about that, but I think that one of the things that can be helpful, one of the pieces of advice I would say is, these conditions are a scenario where you really have to advocate for your health. A lot of times because these diseases are under diagnosed, there's less awareness among the general healthcare population. Many people can experience delay in diagnosis or needing to see multiple physicians before the diagnosis is ultimately made. And so I think throughout this journey, it's really important that if there's a problem or something's going on and you feel like you're not getting the answers you need, go to people, first be direct with your physicians about what's going on, but also not be afraid to continue to seek those opinions until those problems are addressed. So I think in my observation, a lot of times the people that get diagnosed earlier, those that kind of push, the patient and their family members push to get those answers and get those referrals. So I think that that's one important aspect of this journey with people with amyloidosis. The second thing is, don't be afraid to ask questions during the appointments. Um, we're fortunate here to have ample time to discuss these things in our clinic visits, and so that's where I hope to a lot of time is to really delve into what questions patients have. So I kind of think about small part of talking about getting the history and exam and talking about the diagnosis, but really trying to leave most of that discussion to be a conversation about specific questions and concerns. So I'd encourage patients to really use that time and bring their questions.
Yeah, you make a great point about kind of advocating for yourself, and I thought it was interesting how you said that you find the patients who get diagnosed the earliest are often the ones who kind of are the best advocates for themselves and for their family members. And I couldn't agree more. I think that's something that's so important, but kind of on the other hand, it's something that's extremely hard to do. To challenge, not necessarily challenge, that might be too strong a word, but um, really to advocate and push for yourself when you feel like the person who you're working with, the doctor, the medical professional, is much more knowledgeable in a subject than you are. And I think that's a bit of a barrier, but something certainly to stress to all patients that you should be advocating for yourself. And like you said, if you're not happy with the opinion that you receive, that you go and seek another one. And that's something that all patients should keep in the back of their mind, regardless of the condition that they have. But to switch gears and talk about a subject I personally find very exciting, and that's advancements in treatment, particularly ATTR, has been astounding. We've gone from zero to seemingly 100 in a very short amount of time, and the pipeline of potential drugs is still so rich. And we're fortunate to have so many choices. But how might you summarize, as a medical provider, how you choose treatments and how patients are involved in making decisions surrounding treatment, and how you are able to manage expectations when discussing treatment options with patients?
Yeah, absolutely. So I guess just kind of a quick 30,000-foot view of where we are with treatments for ATTR in June of 2025. I have to
Mm,
go by the month now because things change so quickly, it seems.
what
Uh,
a great problem to have, though.
yeah, great problem to have for sure. And so, yeah, exciting times, like you said, for the options for patients and emergence of therapies that improve survival and other really important outcomes. So, we have a couple of medications now, which we call transthyretin stabilizers, that are small molecules that bind to the transthyretin protein and help prevent it from breaking apart and forming new amyloid. And those drugs are acoramidis and tafamidis. And acoramidis came out late last year. Tafamidis has been out for several years now. Both have demonstrated significant benefits in terms of improving survival and reducing things like hospitalizations and improving how patients feel. And a few months ago, we had a third therapy that was approved called vutrisiran, which is works a little bit differently in terms of how it decreases the production of amyloid. It targets the liver and decreases the amount of transthyretin that's produced in the liver, and therefore you have less protein that goes on to make amyloid. And again, also showed significant improvements in survival and hospitalizations. So, we've quickly gone from, having one treatment into the last, 6, 7 months to having three options available. They're all very effective. To date, we don't have any information directly comparing these three to each other. So it's difficult to say that one's clearly better or we should use one exclusively over the others. And so, I think that some of my colleagues at conferences have, you know, um, described the landscape very well in terms of how to approach using these therapies. And this is where I think patient input is crucial, and it's really a shared decision making. Going through what we know in terms of how these are effective, like I mentioned, and what we don't know, which is the comparison of these drugs among themselves. They're all a little bit different in terms of how you take them, pills versus injections, and how often you take them, and then there's cost considerations with insurance. Um, and so I think with all that information, coming up with a decision between the patient and physician is what my approach has been these last few months with all these options available. Hopefully, we'll continue to get more data in the coming years that help guide us and maybe which scenarios to choose one versus the other, or is there a role for combinations of these? And so I do think that we'll continue to get those data, and those will be helpful. But the patient voice and the patient preference are always going to be, I think, key in terms of how to navigate these choices. Like you said earlier, it's a good problem to have. These options, and perhaps if someone's not doing it well on one treatment approach, now we have the options to make adjustments. And so I think it's a really exciting time.
Yeah, there's really more hope than ever, and I'm so grateful that that's kind of the position that we're in right now. And it's clear from what you described that choosing treatments is nuanced and a little bit tricky. And diagnosing amyloidosis is the same way, and that also includes determining the correct type of the disease. And I'm just curious to get your thoughts on, are we getting better at diagnosing amyloidosis, or do you think there's an element where we're raising awareness, but maybe there's a little bit more false positives when it comes to amyloidosis? For example, um, one thing that comes to mind is PYP scans and interpreting imaging, wall thickness, things like that. Are we getting it right? Are we diagnosing the correct population?
Yeah, yeah. So maybe to answer the last part of that first. I mean, I think that the use of nuclear scintigraphy scans, including PYP, have given us in the last several years a non-invasive way to diagnose ATTR in a lot of folks. And the facilities that can do these scans is much broader than the places that could do heart biopsies, which was previously, the way the majority of people were diagnosed. With that, that's led to an increase in the diagnosis rate, which is a good thing.
Hmm.
But there's also inherently some degree of false positives that you mentioned. And so I think the net result is positive that we're diagnosing more patients than we are kind of false positives. I think there's work to do to continue to improve the accuracy, particularly in those places that are just adopting that scan, to make sure
Hmm.
that it's being performed in the right way. And, um, found the associations such as ASNC, which is the American Society of Nuclear Cardiology, published guidelines. And so hopefully we can continue to implement standard practice in these areas. In terms of where we are with diagnosis rates of ATTR, I guess, and this is also AL, is I think we're better than we were 5 years ago, but we still have a long way to go. So I think the majority of people are still undiagnosed. And so we need to continue to raise awareness among the healthcare community,
Mhm.
continue to raise awareness among patients, and then kind of to go back to our discussion earlier about the advocating for your healthcare as a patient and caregiver. I think that that's certainly an important piece, but I think you nicely pointed out that um, that can be daunting and have its challenges. So while I think that that's an important part of it, as physicians, as a healthcare community, we have to figure out how to better meet patients where they are, and you know, not only raise awareness among community practices, but how as we as amyloid centers of excellence um, improve the ability to diagnose patients in these communities. And I think that's where automation comes in with AI, machine learning, that we hear a lot about.
Mm.
We know a lot about what the signs look like in various imaging modalities and tests. So, how do we apply that to these large electronic health records, which many of our practices belong to now, to at least raise suspicion for patients that should be referred to amyloid centers, or should you should consider amyloid? And I think that's going to be another way to identify some patients that have previously been missed. So, I don't think it's a one size fits all solution about improving diagnosis rate. I think there's education among uh, providers as well as patients. And then there's an overlay of how do we automate some of this process, because um, I was talking to a primary care doctor over the weekend at a meeting I was at. All the things that they have to think through. I mean, amyloid is just a small piece of that. I mean, you have cancer prevention, you have all these other diseases. So I think the expectation is say, hey, remember this, fairly complex algorithm, apply that to the 1 out of 1,000 patients pick up amyloid. Well, that's nice. Maybe some people do that, but we need to take some of that burden off of them. And I think that's where the EHR automation and screening could help with that, be an assist.
Yeah, I think that's a really interesting point. And like you said, it really is nuanced because there's only kind of so much that patients can do to get diagnosed, right? They can't go to their provider and say, "Hey, I think I have amyloid," except for in a very select handful of cases where there may be a hereditary component to their disease. And then, like you said, there's the component of medical professionals educating medical professionals. And I think that, is a big part of it, but everyone's limited in their time. So when you mention the kind of the AI component, I think that's really interesting because it can also help to capture some of those rural communities, like you said, who don't have access to a center like Stanford or Mayo or, so on and so forth. And I think it just brings a level of accessibility to them. And a lot of the times these symptoms are so vague. Like someone may have like orthostatic hypotension and the differential list is forever long. And like you said, that primary care physician already has to think about so many different things. So having a kind of a tool that can help providers that's integrated into their electronic health record, I think could be something that's truly game changing and life changing for these patients to kind of get a diagnosis as quickly as possible based on the information that's already in their medical record. Um, but just a really interesting point I think you made, and a really exciting application that I hope becomes a part of medicine. Um, but anyways, to kind of start to wrap up our conversation, I think there's one really important topic that I'd like to talk to you about, and that is the work that needs to be done to better engage the African American community, and particularly in the setting of hereditary ATTR and the V122I variant. And there's just so much work to be done. And certainly this relates to understanding family histories and the diagnosis of this genetic variant, but also in areas such as clinical trials. There's a growing list of FDA approved drugs, like we talked about earlier, and much can be done to improve patient lives and reduce disease related mortality. So, how are we doing in terms of raising awareness to help this specific community with this variant? And what can we be doing better?
Yeah, I think broad, complex question, and we could
Yeah.
spend an hour talking about it. Uh,
It could be its own episode, certainly, but just kind of like a 30,000 foot view, because I think this is a really targetable area where we can make a big impact.
So I guess I would kind of split it into two areas of thought. So we know that this variant, which is fairly prevalent among Black individuals, increases the risk of ATTR. So about 4% of Black individuals carry this. And so this is a risk factor, like there's risk factors for other cardiovascular diseases that we can target a smaller population of patients and think about how certain interventions or screening might pick up cases sooner. And so this is where I think if you're over the age of 50 and you're Black and you have heart failure, this should be something that comes to mind. And now we have these non-invasive tools to diagnose most people. So that's kind of an implementation part of things based on a biologic uh, factor.
Mhm.
Um, and the second part of it is that just and this is not as specific to Black individuals, but there are groups that have historically less access to care, whether they're Black or other races. And there's an overlay of things like urban versus rural, socioeconomic status. So these are kind of structural barriers to diagnosis. And so here I think that I look at it more broadly beyond the V122I variant or Black individuals and say, hey, how can we improve diagnosis rates in rural areas? How can we improve diagnosis rates in areas with less, kind of economic resources. Um, and we published data in Jack Heart Failure Journal a few months ago, really showing the impact of social determinants of health on access and diagnosis rate. And what we saw is that areas where zip codes where patients came from zip codes with a high social deprivation index, so more people along the poverty line, limited access to transportation, et cetera, they were twice as likely to present with late stage ATTR at their first visit compared to higher socioeconomic areas. And this was independent of race. It was independent of the distance from our amyloid center. Uh,
Mhm.
and so I think that highlights to me that these are areas that need more resources to improve their ability to get to centers like ours, and also to recognize that some of the testing and other interventions do come at a cost. And so, is there a way that we can do these screening algorithms in a more efficient and economic way? So that's kind of more of a health policy, health economics lens. So um, I guess kind of to sum up that answer to your question, I think that there's certain kind of knowing this biologic information, the V122I variant gives us some clues into what populations we should do more focused screening. But I think the other part of it is how do we remove or alleviate some of the structural barriers to healthcare that exist beyond V122I and ATTR. And I think this is where we can piggyback on efforts in other diseases, for reducing stroke and reducing coronary artery disease, hypertension, et cetera. So the barriers that exist to kind of treating those conditions are also similar to, treating ATTR.
Yeah, it's interesting to think about how we can pull from what other diseases have done and try to increase that access to care. And like you mentioned earlier, something that your center does is just having more accessible communication, telemedicine to try to alleviate some of those barriers. While you know we can't always have telemedicine, we have to see people in person to know that you could do kind of a lot of the majority of your care online to be able to still have access to some of these centers while conserving resources is really important. So just an important exercise to think about and be aware of. But in closing, I want to thank you so much for your time today and for everything that you do to care for and support our amyloidosis community.
Yeah, thanks for having me. Always happy to chat.
Of course. So just in closing, kind of last question, a fun thought exercise, and that's getting your thoughts and opinions on where do you think cardiac amyloidosis is in 10 years, and you know any other comments that you'd like to offer our listeners.
Yeah, so in 10 years, I'm an optimistic person. So, I hope that we have a cure for most people. So meaning that we diagnose the disease and not only do we slow it down, but we stop it or even reverse the disease. That'd be my goal. And then I think for ATTR, we get to a place where we can prevent this disease for many people. So if you have a TTR mutation and no disease, can we start a treatment or intervention so that you never develop amyloid? And perhaps for wild type 2, maybe we figure out who's going to develop wild type ATTR and we can start a treatment before the disease becomes manifest.
Yeah, I have to be honest, I certainly did not expect you to say cure,
Yeah,
but
yeah. Like I said, I'm a glass half full person, so that's the
that's a
hope.
full glass, and I would love that as well. I think all of our listeners would, and you know, every day we get a little bit closer to that goal. So thank you again. I appreciate having you on.
Yeah, my pleasure.
So, in closing, although amyloidosis remains a rare disease, it's looking more and more likely that amyloidosis isn't a singular disease, meaning our knowledge advancements are starting to reveal that AL is not ATTR and wild type ATTR is not hereditary ATTR. And although symptoms may be overlapping, the diagnostic pathways diverge, and treatments are strongly defined by type. As Dr. Alexander shared, there is great hope for treating amyloidosis, but there remains much work to be done. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.